I will introduce, as is our tradition, I will introduce the person who introduces the speaker. We haven't yet introduced anyone to introduce me to introduce the introducer of the speaker. So in terms of local activities, we have the residents' graduation party, or the residents, not graduation party, but just the department residents party, but open to all faculty, on Saturday at the Graduate Club. I think there's still room to sign up, so I encourage you to do so. It's always fun. It's a fun place. It's a fun evening, and of course the Yale Psychiatry combo will be performing. David Sasso, Frank Fortunati, etc. Next week is the last Grand Rounds of the year, and it's Petros Lavounis, who from University Hospital, whose title of their talk is "It's not okay not to know what Grindr is: methamphetamine use among gay men." This is a topic obviously very important, and one that many of us have a lot to learn about. So I think be a very important Grand Rounds, and hope to see you there. So at this point, I will introduce. Oh, and the CMHC party is Friday night next week. So it's a week. The residence party is a week from Saturday, and a week from today is the CMHC party. Also, a wonderful gala event that I hope you will attend. Okay.
So good morning. So today it's my pleasure to introduce Dr. Lisa Fucito. Lisa received her PhD in clinical psychology from American University in Washington, D.C. And after completing her doctoral work, she's been at Yale ever since. She joined us as a predoctoral fellowship at the Substance Abuse Treatment Unit. And then after completing that, she joined the faculty first as an ARS and then as an assistant professor. Since joining the faculty as assistant professor, she's held a K-23 Career Development Award from NIAAA to develop more effective treatments for heavy drinking smokers. And since 8/15, she's been the director of the Tobacco Treatment Service at Smilow Cancer Hospital at Yale New Haven Hospital, a role in which she has demonstrated considerable clinical and administrative acumen. That is one of the things I would like to just highlight about Lisa once you get to know her. She really is one of the very best clinicians I know in terms of treating addictive disorders, especially in young adults, but also in patients that have complicated comorbidities. Her own program of research is focused on the development of treatments for alcohol and tobacco use that can be integrated. And when we talk about integrated, we mean it can be integrated into primary care settings where people show up more often than in specialty care. It means integrated, involving approaches that can address more than one problem at a time, like alcohol and tobacco, because most patients have more than one health behavior problem. And she also is interested in how you can leverage a patient's presenting concern, such as sleep, to engage them in doing something about their heavy drinking, as another example. So this research that she's going to be presenting today, in fact, is informed by her considerable experience working with young adults in clinical research settings. In addition to training in college counseling centers while she was in graduate school, during her postdoctoral fellowship, she provided counseling for students at UNH who were mandated for alcoholism treatment. And then she supervised the program and the fellows working in that position. She started off coordinating a clinical trial of naltrexone for alcohol dependence in young adults. And these experiences, though, really piqued her interest in thinking about novel ways to engage young adults in treatment and reduce their substantial risk for problems. So this is what we're going to hear about today. So join me in welcoming Lisa to the podium.
Okay, I have quite a challenge this morning. It's really, really hot, and I'm talking about sleep, so I hope I can keep you all awake this morning. And hopefully you can hear me okay. So I'm going to be talking about my program of research that's focused on sleep and alcohol use in young people. And I just want to highlight a disclosure at the outset that the program that I've developed, specifically the program called A Night, or clever name, it has actually been registered with the Patent and Trademark Office. And as Stephanie mentioned, I also have NIH funding that has supported this research. So just to provide you with a little bit of an outline of what I'll be talking about today, I'll briefly mention why sleep problems are important. I'll highlight the prevalence of these problems and indicate the risks that are associated with them. I'll also provide a brief overview about what is known about alcohol and sleep generally, and then go into more detail about what's known specifically about adolescents and young adults and highlight some of the work that I've been doing in this area. And then I'll end with a discussion of the intervention that I've developed. So this is a nice picture from the National Heart, Blood, and Lung Institute that I think really highlights the problem with sleep and why it's an area that I'm really interested in. So let me make sure I can get this pointer to work. So sleep problems are quite common. So an estimated 50 to 70 million US adults have problems with their sleep or problems with wakefulness. The majority of us are, particularly young people, are not getting enough sleep. So that's an area that I'm particularly concerned about, is that an estimated 70% of high school students are not getting enough sleep on school nights. Women in particular are more prone to sleep problems. A number of us are not getting enough sleep at night, and that's translating to a lot of difficulty functioning during the day. And these common sleep problems are quite costly. So it's estimated that there's essentially $50 billion in lost productivity as a result of people not getting enough sleep. And particularly concerning is it's estimated that fatalities as a result of car accidents can be tied to drowsy driving. So sleep problems are common and costly, and they're also linked with a lot of different medical problems. So as we can see here, it's linked to heart disease, stroke, diabetes, obesity, cancer, high blood pressure. And we know as mental health professionals that sleep problems are often a symptom of psychiatric disorders or a consequence of psychiatric disorders. And more emerging research is suggesting that it actually may be a risk factor for the development of a psychiatric problem, including addictive disorders, which I'll talk about. So what is generally known about alcohol and sleep? So for this, we can turn to epidemiology data, and what we know is that alcohol is the most widely used drug that individuals use to self-medicate sleep problems. We also know that sleep problems tend to be elevated among individuals with an alcohol use disorder, and likewise, alcohol use disorders tend to be elevated among individuals who have sleep problems. When we look at experimental research, we also learn that sleep is very much affected by alcohol use. In particular, alcohol has negative effects on sleep architecture. And to try to put these findings into context for you, it's probably helpful for me to explain what the sort of typical pattern of sleep is for adults. So we typically think of sleep as being divided between the first half of night sleep and the second half of the night sleep. And during the first half of sleep, we typically spend a lot more time in deeper stages of sleep, which are characterized by slower brainwave activity. As we progress towards the morning, as we go into the second half of sleep, we tend to spend a lot more time in lighter stages of sleep, sleep that's characterized by rapid eye movement. So that's sort of the context of how we typically sleep. Then what happens when we actually add alcohol on board? So these studies are based on what are the effects of alcohol on normal sleep, so individuals who don't have an actual disorder. And what we see during the first half of sleep is that alcohol actually helps to promote sleep. And these findings typically hold for moderate to heavy doses of alcohol. So it typically facilitates falling asleep, and it facilitates falling asleep into a deeper level of sleep. It also helps to decrease our likelihood of waking up during that first course of sleep, and it decreases the amount of time we spend in REM sleep. So it seems to be helpful in promoting sleep during the first half of the night. But what happens during the second half of sleep? Well, that's when we see more of a disruption. So because we spent more time in deeper stages of sleep, we then see a rebound such that we tend to then spend more time in lighter stages of sleep. And we also start to wake up a lot more. We start to have more fragmented sleep. But this aspect here is what drives a lot of individuals to self-medicate their sleep with alcohol. problem is that this tends to be short-lived. It's not an effective strategy in the long term, because what we see is that within about a week's worth of use, this sleep-promoting benefit goes away. We become tolerant to it. So those were the effects of alcohol on sleep among individuals without a disorder. But what happens once you actually develop an alcohol use disorder? Well, here, unfortunately, alcohol is quite disruptive. So we see that overall individuals with alcohol use disorders have much less sleep. We also see that even though, interestingly, they may have turned to alcohol to help them fall asleep, that now it's actually causing them to have greater difficulty falling asleep. So it's actually taking them longer to fall asleep. And upon withdrawal, insomnia is a very common problem that can persist for quite some time. So that's what is known generally about alcohol and sleep, but what about the sleep and alcohol risks in young people? So it's important to highlight that there are developmental changes that occur around puberty that continue into young adulthood. And these are important changes that occur in sleep. And oops, I'm getting to more exciting stuff ahead of time. So what specifically happens at the time of puberty? Well, in particular, we see that there's actually an increased need for sleep. And we also see that sleep actually starts to shift later. So there's a preference for going to bed later. There's a preference for waking up later. So those of you who remember being a teenager, who have high school students, probably can relate well to this. The problem is that preference for sleep, that sleep pattern, is often in conflict with societal demands. So we look at high school start times, for example. They typically are around 7 or 7:30 in the morning, and that's usually at odds with when most adolescents want to be getting up. So we actually have the younger children who get picked up by the bus later, but it's probably the high school students who should be picked up around 8 o'clock or 8:30. And so in an attempt for adolescents to try to cope with this preference for sleeping later, but then having to get up earlier, they maintain very erratic sleep schedules. They may experience insufficient sleep. They may attempt to make up for sleep on the weekends. And as a result of these sleep difficulties, what we see is that sleep deprivation is very common. In particular, about 2/3 of high school students are experiencing excessive daytime sleepiness, so they're falling asleep in class. They're not really benefiting from being able to be in class. It's just so tiring for them to be there. As well, we see about 1/3 of young adults are also experiencing this excessive daytime sleepiness. And the intervention that I'll be talking about, particularly was for college students, we see that these rates are even higher among college students. Unfortunately, the college environment can make it even more challenging for college students to get sufficient sleep. And then over time, we see that the difficulties with trying to maintain the appropriate schedule for their demands, their preference for sleeping later, can ultimately put young people at risk for sleep disturbance, poor sleep quality, actual insomnia symptoms, irregular sleep patterns, and so forth. At the same time, when we see these important developmental changes occurring in sleep, we also see important developmental changes occurring in initiation of alcohol and substance use. And this is a survey, the National Survey on Drug Use and Health, which highlights the risks that I'm interested in terms of alcohol use among young adults. So from this survey, we see the percent using in the past month, and there are 3 categories that this survey reports on. So we report on, in the light blue, we're reporting on just actual use of alcohol. In the gray bars here, we're reporting on binge alcohol use, which for the purposes of this survey, they defined as at least 5 or more drinks on one occasion in the past month. And for heavy use, it's at least 5 drinks on at least 5 occasions in the past month. And so this is basically looked at across the lifespan. And so we see that around adolescence, we start to see the initiation of alcohol use. And then once we get to young adulthood, the overall rates of alcohol use are somewhat comparable. But what's really striking is the onset of binge and heavy alcohol use. We see that peaks at this time period. We also know a phenomenon that's quite common is that a number of individuals graduate out of this heavy binge alcohol use. But nevertheless, a number of individuals struggle with this. So the emerging responsibilities of work and adulthood and parenting often facilitate people reducing their drinking, but a number of people stay stuck at this level. And so our alcohol prevention and intervention efforts ideally should really be focused on this time period, because this is the opportunity where we can try to intervene early to prevent the development of a chronic problem. And just in terms of the risks that are associated with this alcohol use, In the United States in 2005, for example, rates of alcohol use in young people were associated with 600,000 injuries. An estimated 700,000 were injured by another student as a result of alcohol use. We know that this is a risk factor for sexual assaults and date rape. And binge drinking in particular is associated with very serious consequences: vandalism, physical injuries, legal consequences, and other negative consequences for health. So obviously a very important issue we need to do more about. So what are the links between sleep and alcohol use in young people? The majority of research that's focused on this issue has been cross-sectional. And what we see is a number of different sleep variables are linked with greater alcohol use. And I'll highlight a few of them. So in particular, we see those individuals who experience greater sleep-related impairment tend to report more alcohol use. Those young adults and adolescents who report greater insomnia symptoms, so greater difficulty initiating and maintaining sleep, again, report greater alcohol use. And also, those who report greater eveningness. So this is, for those of you who may not be as familiar with this terminology, this is one's chronotype. So we all have kind of a preference in terms of, do we tend to like to have more of our activities happen in the evening time, or are we more larks, morning types, where we tend to like to get up early and start our day and have more of our activities occur in the daytime? So those who categorize themselves as more evening types, or who have more delayed sleep patterns, also report greater alcohol use. And more recent research suggests that there may be this potential synergistic effect of poor sleep and alcohol use. In particular, 2 studies suggest that poor sleep may increase the risk of experiencing consequences from alcohol. And I'll walk us through this figure over here. This is research done by Shannon Kenny and colleagues. And this particular study was also replicated by colleagues up at Brown, in particular Kate Carey. And what we see here on the y-axis are negative consequences as a result of alcohol use, specifically alcohol-related consequences. And what we see on the x-axis is weekly alcohol consumption. So those at the lower end here report less alcohol use, and those at the higher standard deviation up here are reporting heavier alcohol use. Then I'll explain these lines. So we see this is the line for individuals who reported having good sleep, and this dashed line are the individuals who reported having poor sleep. So what we see is this interesting finding that at lower levels of alcohol consumption, your sleep doesn't seem to matter in terms of your risk for experiencing harm from drinking. But once we're at heavier levels of alcohol use, it matters how you're sleeping. They found quite dramatic finding that those who had poorer sleep were at much greater risk of experiencing harm from heavy levels of alcohol use. But nevertheless, cross-sectional research has limitations. So there are a number of different sleep variables that were tied to greater alcohol use involvement, but we don't really understand how these sleep characteristics may vary in presentation among adolescents and young adults. And they don't really help us to understand what is really the nature of sleep that increases risk. So are they all those variables together, or is one in particular more important than the other? So this led me to conduct a study with my colleague, Dr. Kelly DiMartini, where we were interested in trying to understand what are the variations in these sleep characteristics in individuals who are at risk, specifically young adults who are at risk for harm from alcohol use, and what are their experiences of these sleep-related problems. So we conducted a latent profile analysis of self-reported sleep-wake problems in at-risk college student drinkers, and they were identified as being at risk based on a standardized alcohol screener. 312 students, most of them were freshmen, and they reported drinking about 20 drinks per week on average. We conducted a set of analyses to fit 1 through 5 models to see what represented the best fit of the data. And then we examined, after we identified the classes that were the best fit of the data, we examined whether these classes differed on alcohol use and alcohol-related consequences. So this is the instrument that we used. It's called the Sleep-Wake Problem Scale, and it was developed by Mary Carskadden and colleagues up at Brown. And I know it's kind of a busy table here, but this just kind of highlights the different aspects of sleep that are often typical for adolescents and young people. So the first section deals with difficulty actually performing during the day, so actually difficulties in functioning as a result of poor sleep, so not being able to get to class, falling asleep in class. The next set of questions relates to sort of the timing of sleep, so kind of sleeping later, consequences of sleep, and then finally this last section here relates to actual sleep disturbance symptoms. Items are scored from 1 to 5, and you can see this is sort of the overall scoring for the sample. And so we found that a 4-class solution best categorized the sample. And so the reason why you might do a latent profile analysis is rather than just setting an actual cutoff score, using some clinical cutoff score, you look to actually see how the pattern of responses may suggest a particular profile for an individual. So we identified 4 classes, and the majority were characterized by being sleepy and having late bedtimes. The next most common class reported being sleepy, sleeping later, and having some consequences. The next most common class was this last class that was sleepy, reported sleeping late, sleeping in later, but also starting to experience sleep disturbance symptoms. And the least frequent class was just a class that identified as being sleepy. So I'll bring back that summary of symptoms to better explain how we came up with these titles. So again, when you do a latent profile analysis, you look to see the variability within responses. And in particular, you look to see where there may be relative elevations in scores relative to other scores. So again, to return us to this sleepiness class, you see that pretty much they tended to have an elevation on feeling tired and feeling sleepy, but they really didn't, the rest of their profile didn't show any elevations. This next class, the sleepiness with late bedtimes, again, also showed elevations in sleepiness, but here was the beginning of actually starting to sleep later. The next class we identified, again, consistent across all of the categories, is high levels of sleepiness, sleeping, having a sleep timing that was later, but now the beginnings of an actual consequence of having this particular sleep pattern. And this last category was the category that was identified as having the most severe symptoms. So elevations on sleep timing, on sleepiness, but also on actual consequences and sleep disturbance symptoms. And I should mention the way that we've modeled these over here is it was the probability of not having this consequence. So in this case, having lower values here is worse. So how do these classes actually relate to alcohol use and alcohol-related consequences? So to remind you again, this is that class here that had the greatest likelihood of having those consequences and also the most severe symptoms. So not surprisingly, they were the group that was associated with the greatest alcohol use. So this is mean scores on drinks per week. So this is number of drinks reported per week, and these are the classes at the bottom. And similarly, this is alcohol-related consequences. So again, they both had the highest values for alcohol use and alcohol-related consequences. But then we see that the next group that was at risk were these individuals that reported being sleepy but having a later sleep timing. Having the experience of a consequence didn't necessarily make this group more at risk. And then the group with the least amount of risk is this group that just tends to report being sleepy. So what do we take away from this? Well, at-risk college drinkers report high levels of sleepiness, so that was consistent across the board that this is a sleepy population. They report moderate sleep-wake problems, and delayed sleep patterns are common. And in particular, latent class was related to drinking and alcohol-related consequences, such that those who had the highest level of sleep-wake problems had the greatest alcohol-related risks. We were excited by the findings, but nevertheless, that study was still cross-sectional. So we really need to be turning to other types of research to better understand the nature of this association. So longitudinal studies have tried to look at more of a temporal association, so studying sleep earlier during the lifespan and whether or not that's predictive of risk for drinking. And there's been a series of studies that have been conducted by Maria Wong and colleagues and Brand Hassler, where they looked at childhood sleep problems. So in the first set of studies, they looked at maternal ratings of sleep problems of children, and they also looked in Brandt's study, for example, of children who rated their own sleep as children. And not surprisingly, we see that those who had greater problems with sleep as children had an earlier initiation of alcohol use, an earlier onset of an alcohol use disorder as adolescents, and had greater binge alcohol use, greater consequences from their alcohol use as young adults. Longitudinal research has also looked at sleep during adolescence. There are national adolescent health surveys that have tried to look at across different waves, what happens at the first wave during early adolescence, and what is the potential risk on alcohol use at subsequent waves. And what we see that those adolescents who reported having sleep problems at the first wave were at greater risk for having binge drinking and alcohol-related consequences at the subsequent waves. And similarly, in adolescents with insomnia symptoms without any alcohol use disorder symptoms at subsequent follow-ups have been identified as having alcohol use disorder symptoms. So there may be something to sleep being a potential early risk factor for developing an alcohol use problem. But nevertheless, this research is still limited. It doesn't really clarify causality for us because, one can make the argument that, well, it's possible that your risk of having a sleep problem and your risk of developing an alcohol use disorder are shared by some third variable. So there may be some risk factor that predicts your likelihood of experiencing both, and perhaps the first risk that manifests are sleep problems. So this research is important, but it still doesn't necessarily help us understand causality. So to better understand this, we've tried to turn to some other types of analyses that we can conduct to try to get at a little bit more of a hint of causality in terms of how sleep may put individuals at risk for drinking and vice versa. So this is a study that I'm promising everybody we're getting out before Christmas, that I've conducted with many of my colleagues here, along with Eliza Van Reen up at Brown. And we were interested in answering two questions. So do young adults, does their alcohol use affect their subsequent sleep? Because that would get a hint at causality, right? So what happens following their alcohol use? And does their sleep actually affect their subsequent drinking? So for this week, conducted a daily experiencing sampling study of at-risk young adult drinkers, and they were identified as being, there's a common theme throughout this, at-risk drinkers identified by a standardized alcohol screener. And in this case, they had to report at least one occasion of heavy alcohol use in the past month. On average, they were about 20 years old, and they had reported, on average, drinking about 19 drinks per week. They were asked to complete daily diaries of sleep and alcohol use for 1 week, and they were also asked to wear a validated sleep-wake activity monitor, an ActiWatch, which is a bit more sophisticated than a Fitbit, a bit more expensive too, and they were asked to do that for 1 week. So then what we did is we used hierarchical linear modeling, and I should say Kristen Bold used hierarchical linear modeling for us, and we then used that to examine these dynamic bidirectional relations among sleep characteristics and alcohol use. For the measures, we used the Pittsburgh Sleep Diary, and participants were asked to report the next morning how they feel that they slept, and also record how many drinks they had consumed the day before. And then the ActiWatch recorded a number of these objective sleep characteristics. These actual daily reports generated a total of close to 300 daily reports. So we had 42 subjects, but we were able to get close to 300 daily reports of data. In the first models, we were interested in looking at those time-lagged associations between alcohol use and subsequent sleep indices. And in the second models, we were interested in time-lagged associations between sleep indices and alcohol use. So what did we find in the first set of models? And I should highlight that this kind of modeling strategy allows you to understand variability within a person, so how one person tends to sleep, how that tends to affect their drinking and vice versa. But it also allows you to compare between individuals. So do some people who tend to sleep a certain way, do they tend to drink a certain way? So in the first set of models, we observed significant within-person and between-person level effects, such that on days when individuals consumed a greater number of drinks than they usually had, they had a later bedtime that night, and they slept in later the next day. We also observed a significant between-person level effect, such that individuals who tended to consume more drinks than others had significantly shorter sleep durations. In the second set of models, we again observed a significant within-person level effect, as well as a significant between-person level effect, such that on days when individuals had an earlier wake time than usual, shorter sleep duration than usual, or perceived that their sleep quality was greater the night before, they consumed significantly more drinks. So each one was a significant predictor. I can say we did conduct the horse race analysis to see what happens when you put them all in there together. And sleep duration is the only variable that drops from that multivariate model. We then observed a significant between-person level effect, such that individuals who tend to just feel more alert when they wake up tend to drink more. Okay, so how do we attempt to make sense of these findings? What possibly might be a a model that explains these relationships. So what we saw was that alcohol use delayed sleep. And we saw that potentially shortened sleep, but interestingly not the perception that you hadn't slept well, predicted greater alcohol use. We tend to find this, although we didn't model this and test this in our study, we tend to find that when you delay your sleep, you often get less sleep. But we're interested in trying to understand sort of what are the mechanisms here. So why do we see this association? Why might this possible pathway lead to greater alcohol use? And really that's kind of where we are, the state of our research at this point, both mine and across the field, is we know that there are these relationships, but we don't really know why. And so I'm just going to hint at this because I don't have time to go into a lot more of this information, but my colleagues and I up at Brown were trying to get at the different potential mechanisms that may account for this. And so one hypothesis that I have is that I think that that delayed sleep timing actually delays the underlying circadian rhythm and subsequently may actually alter subjective response to alcohol. And so why am I making this hypothesis? Well, I'm basing this on prior evidence that suggests that this may be possible. So as before, I mentioned that individuals who have that preference for sleeping later tend to report more drinking. We know in animal research that when you alter circadian phase, when you shift animals, and you tend to do that by altering their light-dark cycles, we see that that affects actual ethanol consumption. And there's been research that has shown that when you administer alcohol at different times of the day, you get different responses. And in particular, not surprising probably to everybody, alcohol is more stimulating during happy hour and at night. So there's something to this timing and this experience of alcohol where there may be something going on. And we know in the alcohol field that subjective response to alcohol is a robust predictor of developing an alcohol use problem. In particular, reduced sensitivity to the impairing effects or increased sensitivity to the alcohol stimulating effects, so the rewarding effects of alcohol. So I had an R01 application in to sort of further test this mechanism. Unfortunately, it didn't get funded, but we're going to go back in. But I have the experience of delaying young adults' sleep, dragging them into delaying their sleep, making them go to bed at 4 in the morning, and having them come into the lab and then drinking Everclear and Kool-Aid. And so we have a signal that it seems like they actually experience alcohol very differently. So stay tuned. Hopefully in a few years' time I can come back and sort of elucidate potential mechanisms of this. But this is just to, just sort of highlight some of the work that my colleagues and I are doing. But I think if we do find that this is a potential causal association, I think it has important implications for those of us as providers who actually want to treat young adults. First of all, I think we need obviously more experimental research to prove that there is this causal association. But if we find it, there's actually great sleep interventions that we can use. And they're not very complicated. They're not very expensive. Sleep interventions can change circadian phase. You can get individuals to just adhere to a sleep schedule. So, for example, if you're about to travel, you can actually sort of put yourself on one. Or when you come back, put yourself on a new schedule to try to get yourself adjusted. Light therapy, very effective of shifting circadian phase. Similarly, you can give individuals melatonin. So an area that I'm excited about is if we can show that this delayed phase is causal, if it actually increases potentially your risks for alcohol, if it alters your subjective response in a way that is risky, we might be able to reduce these alcohol-related risks in young people by advancing their circadian phase. So stay tuned. That's the sequel. Okay, so now to turn to the actual intervention work I have done this far. And I was really interested in this question, as Stephanie highlighted, is that, can we intervene on sleep as a way to reduce alcohol-related risks in young people? And this is a study that was part of a center grant study that was funded by the Yale Center for Sleep Disturbance in Acute and Chronic Conditions. And it was a series of studies that we conducted to try to inform an intervention. We first started off with, if we're going to design this, we really need to know what young adults think about this. So we first conducted more of a qualitative study to understand what they thought about alcohol and sleep, as well as whether they actually would be interested in this. So if we built it, would they come? And as Stephanie mentioned, we know a problem with college students and young adults is they don't typically self-identify for treatment. They come to you because they get into trouble, but they probably would not have sought you out if they hadn't gotten into trouble. So we need to find other ways to engage them. They are open to other health interventions, though, and sleep actually is one of the areas that they're interested in. There's also this nice logical placeholder in sleep interventions where you talk about alcohol use. For any of you who've addressed sleep with your patients, you know that at some point you ask people, well, what do you do before you go to sleep? What are your activities like during the day? And there's a logical place where you find out, well, if you're drinking right before you go to sleep, that's disruptive. So there's an actual component of sleep interventions where you would talk about this. So it's possible that sleep could be a good gateway topic. Another reason why this might be a good strategy with young people is that, as I showed earlier in the presentation, there's this possibility that poor sleep and heavy alcohol use is synergistic. So even if we don't necessarily get them to cut back on their drinking, if we improve their sleep, we might in some way reduce their risk of harm from drinking. So taking all that into consideration, we then conducted a mixed method study to try to understand what this population would want. So we recruited college students because in particular we thought this intervention might be best fit for college students, and we asked them to come in and participate in focus group interviews. So we interviewed 24 students who reported having sleep concerns, and we just asked them yes or no. We didn't require that they actually had sleep disturbance. And they had to have reported at least one occasion of heavy drinking in the past month. We had them complete quantitative assessments, and then they participated in focus group interviews. And several themes emerged from this research. Well, not surprisingly, sleep is poor in college. So they're not getting enough sleep. Sleep problems were common. And they cited that there are a lot of barriers to getting sufficient sleep. So there are aspects of the college environment you can't really control, some of your environment to sleep better. You have the presence of roommates. But probably the most common barrier to getting enough sleep is that there are just so many things going on, and that perception that, I don't want to miss it. These are supposed to be the best years of my life, and I've got, social activities, I've got academics, I've got all these things that I want to do, and I'm just going to sleep later. And that, I think, is a good example of that is the quote from one of the college student interviewees. They were using a lot of strategies to try to help them get sleep. Most common were over-the-counter sleep aids. A lot of them were using illicit drugs. Surprisingly to us, alcohol wasn't one of the more common ones that they were using. And they were using sleep apps and technology and so forth. This, I think, highlights well what is getting in the way of their sleep. Technology. Technology is so much more available now, and in particular to young people, than it was years ago. And there's two risks that are associated with this technology. First of all, young people told us, I sleep with my phone, I'm connected all the time, I come home and I'm up until, 3 o'clock in the morning. Streaming videos is also a bad thing. Those of us in the room who may have gotten caught on, I'll just do one more episode. What happens is it just causes you to delay your sleep, right? But another problem with technology is that the light that is emitted from these devices is actually sufficient to delay melatonin. So not only does the distraction cause you to go to bed later, the actual light that's emitted may also be disruptive to your sleep. They also have a lot of stressful academic considerations that keep them up, and also social activities that they don't want to miss out on. So then we asked them, what do you think about alcohol and sleep? What are your perceptions of the two of them? Everybody thought that it helped them fall asleep. But after that point, there was kind of a mixed response in terms of whether it was helpful or not. Some really thought that it might help them go to sleep, but then it became very disruptive at that point. And this was a good example of a student who said, that I get worse quality of sleep when I drink, so I'll wake up at like 7 in the morning, even if I've stayed out until 2 a.m. the night before, just because I'm sobering up, and then I'll have difficulties falling back asleep. It was really interesting in the interviews because we observed that there were clearly a number of students who really challenged us on this notion that it possibly wasn't good for their sleep. So it's interesting how at this developmental stage, the learning experiences that young adults are having, that, there were students who said, I sleep better, and I think alcohol is really helpful for me. So then we wanted to know what they thought of an intervention, particularly a sleep intervention, and we decided to make it web-based because early on in the interviews, no one wanted to actually see an in-person clinician. So we learned kind of early on that they wanted this to be web-based. So the idea of a sleep intervention they were interested in, but they had very specific preferences for content. So they said to us, if you're going to include something about alcohol in there, we are bombarded with alcohol interventions. We get to college, we're required to go through these different computerized programs. We just turn them on and point and click, point and click, and point and click, and we don't really engage in the material, but we know we have to do it. So please don't show us what everybody shows us. Please make it different. So they were really excited about this idea that sleep and alcohol may have this interesting relationship, and we had shared with them some little tidbits about what alcohol can do to sleep, and they were quite surprised and found that information really helpful. They also, of course, wanted us to make this the next version of Facebook or Instagram, as you can see, easy to navigate, constantly updating information, really easy to track. So, this was their wish list. Whether we met that wish list in the follow-up study is the test, of course. So now I'll close with talking about the actual intervention. Call it a night. We decided we wanted a cool, catchy name for our program. It has that double meaning of helping you get to sleep, but also helping you to just say no to that next drink. This is currently under review at the Primary Alcohol Journal for the Alcohol Society. So as I mentioned, this was funded by the Yale Center for Sleep Disturbance in Acute and Chronic Conditions. The principal investigators of that sleep center are Nancy Redeker from the School of Nursing and Clara Yagi, who's part of internal medicine. So we're interested in designing an intervention, following up on that research, and looking to see, is it feasible? Could we get young adults to do this? Would it be acceptable to them? And would it actually have any preliminary effects on sleep and alcohol use? So we recruited 42 college students who, again, reported sleep concerns just based on yes, no, and who had at least one occasion of heavy drinking in the past month. In terms of feasibility, we looked at patterns of usage using Google Analytics, and we looked at acceptability based on their satisfaction ratings at the end of treatment. In terms of efficacy, we looked at the objective sleep characteristics over time using the ActiWatch, subjective sleep ratings, as well as alcohol use and consequences. In terms of the procedures, we required that all students undergo 1 week of sleep monitoring, because we were going to be using sleep monitoring as a way to track our outcomes. So they had to complete daily diaries based on their sleep, and also included in that to record their alcohol use, and they were going to be asked to wear the ActiWatch. They had to show sufficient compliance to be randomized into the actual trial, and I would say we only lost a handful of people, I think about 4 people, as a result of not meeting sufficient compliance. Once they made it into the actual part of the intervention, they went through a 4-week treatment program, again, that was web-based. So modules opened up at the end of a week. So, and this was, we kind of borrowed this idea from Shut-Eye, which is a computerized insomnia sleep program. So essentially they got their first module, and then at the end of that week, their next module unlocked, and so forth. And then they came back in that last week and to pick up their self-monitoring materials again, so they monitored for another week. At the end of treatment, they completed a follow-up, an assessment of their responses, and then at 3 months, they participated in a follow-up. So I'm going to go through all the different modules, but I'll try to provide sort of an overall overview of these interventions before going into the specifics. We really struggled with how do we have an appropriate attention control condition, and I know in behavioral intervention research that's often our challenge of you have to put a little bit in there, but not too much, and how do you do it so it's engaging and that it has face validity, but how do you do it so it's not too helpful? So I'll start with sort of the overview of how we decided to approach the call to night intervention. What we focused on were the evidence-based intervention strategies that have been shown to be effective for reducing alcohol in young adults, specifically college students. We also focused on the evidence-based strategies that have been shown to promote sleep in young people. So we wanted to really, put a lot of these evidence-based components in there. We also wanted to make it a little bit personalized. So we were going to have the web-based program interface with the intake survey data so that when young people logged in, they could get a little bit of a snapshot of what their profile looked like. We also thought we should focus in on a couple of aspects of sleep based on what came out in the focus group interviews, based on what's come out from all of our other research, what would be the particular sleep intervention strategies that might be helpful. So basic sleep hygiene. I mean, this is just a group that's not sleeping well in terms of their habits. They're just maintaining habits that are not really conducive for sleep. So we thought we really needed to go into a lot of basic advice about sleep hygiene, which in insomnia treatment isn't necessarily known to be an effective ingredient, but in this population, it's likely to be helpful. Sleep stimulus control. So another problem that happens with this population is they do everything in their bed, in their dorm room. And so as a result, their bed and bedroom is no longer serving as a really robust cue for sleep. So you have to actually help them to figure out how they're going to still do activities in their room and in their bed so that they don't impact their sleep. So a good example of this is, the typical tendency for a college student is to get in their bed, start to do their reading, and they're propped up against their pillow, and they wonder why after about 20 minutes they're sound asleep. So what you do is you have them go to the end of their bed, and you have them sit at the end of their bed, and ideally if the bed is up against the wall, you have them kind of sit perpendicular to their bed, so they're sort of up against the wall and sitting that way. And that can actually help you to not fall asleep as much when you're reading on your bed. So we wanted to have very targeted stimulus control strategies for them. And we also wanted to emphasize stress management, because what was clear to us is that this was a very stressed out, anxious group. In terms of the quantitative assessments, they were scoring above standard deviations on clinical cutoff scores in terms of population norms. So we knew that we had to help them with their stress. Okay, so that was the context for Call Tonight. So then what did we try to do for the healthy behaviors control condition? Well, because we were recruiting everybody based on their sleep and wanting help for their sleep, we thought it had to have face validity where it would actually talk about sleep. But we kind of pitched the program as, changing these behaviors will help you with your sleep. We thought we would give them sleep hygiene, but not really go into a lot of detail, not really personalize or tailor it to college students. We thought we would at least mention alcohol use, but again, not incorporate those evidence-based strategies that have been shown to be helpful for college students. So that's sort of the context of the intervention. And so I'll just highlight some of these examples. So everybody got basic information about sleep. In this group, we really emphasized more of the negative effects of poor sleep. We recommended for them to sleep at least 8 hours. This is an age group that should sleep at least 8 hours, ideally possibly 9, depending on if they're still teenagers. This is a group that tends to get about 6, maybe, on a good day. Again, sleep stimulus control, like I talked about. And for sleep hygiene in Call Tonight, we broke it up because we wanted to go into much more detail on why these habits would be important. So in this group, we talked about napping. Napping is actually important for this group. So when people are chronically sleep restricted, you want them to nap, but you don't want them to nap for 4 hours in the afternoon like college students tend to do. And then we wanted them to have some sort of bedtime routine, when to turn off Facebook, where to put the phone, and so forth. In healthy behaviors, they got basic information about sleep, and then they got all of these sort of standard sleep hygiene advice tips. Okay, so into Module 2. So again, here we're breaking up sleep hygiene. Now we're talking about behaviors that are very disruptive to sleep. And we went into a lot more detail about why alcohol is disruptive to sleep. And again, that was what we learned in the focus group interviews, that was helpful. They were actually quite surprised by this. We provided them with a lot of data, some figures, and so forth. We also provided them with these evidence-based strategies for reducing alcohol use in young people. Specifically, you give them normative feedback, so how does their drinking compare to their same age peers? What blood alcohol levels are they getting to? What is blood alcohol level? What does that mean? The advice to drink moderately, and also giving them actual controlled drinking strategies and providing them with information on the effects of alcohol in the body. In the healthy behaviors condition, we gave them USDA guideline information about nutrition, dorm-friendly recipes, so what can you do with ramen noodles, and the advice that healthy eating is helpful for sleep. In the third module, as I mentioned, we really thought that stress was important, so we focused a lot in Call Tonight on relaxation, different strategies that they could use, as well as some very basic cognitive strategies to help them get rid of sleep disruptive thoughts. And in healthy behaviors, we did give them moderate drinking recommendations and this idea that alcohol can be disruptive to sleep, but we didn't go into the evidence-based content that's been helpful to actually get young people to reduce their drinking. The final module, again, we broke up sleep hygiene. Now we were targeting how to actually create a sleep-conducive environment, and we went into a lot more detail on what you can do in college, how you deal with that roommate that is often on a different schedule than you are. And then in the healthy behaviors condition, we talked about exercise, strategies for how to fit exercise into college living, and some example exercises. So now on to our findings. So our primary subjective sleep variables, total score on the Pittsburgh Sleep Quality Index, and a NIH promise measure of sleep-related impairment that actually generates population norms that you can compare scores to. And we also used the ActiWatch. We looked at objective sleep characteristics, and then alcohol use and consequences. This was the sample. You can see no significant differences between the two groups, evenly distributed by men and women, 21 in each group. Probably the only major difference that we can observe is that the Call Tonight group is a bit more diverse. In terms of intervention acceptability, this is based on Google Analytic data as well as their interviews at the treatment exit. So in terms of satisfaction, this is rated on 1 to 10, and again, there's no significant differences between the two conditions. Again, they were moderately satisfied. Thankfully for us, they could understand the material. This is out of 5. Unfortunately, they didn't find it too exciting. In particular, the healthy behaviors condition was not as exciting. I should say that we didn't really have the budget to make this a very interactive website, so this was much more of a passive website. So it was personalized and called a night, so when they brought it up, they got some of their own personalized data. But it was probably a little bit boring from what they're used to, given all these fancy websites now that they interact with. On average, they spent maybe about 15-20 minutes per module. And they had a lot of suggestions for improvement. And probably the most common one, and again, I'm imagining that different questions and hypotheses are building for people who may have seen the different intervention components, but they said, you had us monitor all this stuff, and you never told us anything about it. So that was by far the most common recommendation they had for improvement. So now what did we actually find? So just to highlight you to the next set of figures, down here on the x-axis, we have baseline, week 5, this is the end of treatment, and then the 3-month follow-up. And then we are going to have here all of our primary outcomes. So in this case, this is drink consumed in a typical week. The blue bar, or the blue line, I should say, represents the call to night condition, and green represents the healthy behaviors condition. So for drinks consumed in a typical week, we had a significant effect over time. So both groups significantly decreased from baseline to week 5, and then from week 5 to follow-up. But unfortunately, we didn't see a main effect of condition. Now on to drinks consumed in a heaviest week. We use the daily drinking questionnaire, which is often used with college students. Again, the same time period here, and now this is the number of drinks consumed. Here we see a similar set of findings as before, where both groups significantly reduced over time, so from baseline to week 5 and then from week 5 to follow-up. But here, contrary to what we were expecting, the healthy behaviors group actually decreased at a more significant rate. In terms of alcohol consequences, very similar pattern of findings. We saw that, again, both groups significantly decreased from baseline to week 5 and from week 5 to follow-up. And I should mention that for all of these effects on alcohol and alcohol-related consequences, the effect sizes are in the medium to large range, which was really nice to see. Typically, when you look at brief interventions for college students, the effect sizes are in the small range. So we actually had pretty strong effects over time. We also looked at sleep outcomes. We looked at perceived sleep quality. Again, very similar pattern of findings. Both groups significantly decreased from baseline to week 5, and then from week 5 on to follow-up. But there was no significant effect of condition. And as far as sleep-related impairment, we saw a similar set of findings. This scale is much higher, so it's a little bit harder to see the level of improvement, but again, both significantly decreased from baseline to week 5 and from week 5 to follow-up. And I should say that this particular score, this measure, the NIH PROMIS measure, it's scored using T-scores. So a score of 50 is considered average. And above that is usually indicative of, having clinical problems. So we move them from a level of clinical disruption to a level of better functioning. And again, the improvements in sleep were in the medium to large range. So we had these effects on sleep, we had these effects on alcohol, so we're interested in understanding, is possibly sleep improvement a mechanism of behavior change? So what we did for this is we looked to see what were the effects on sleep between baseline to week 5, and did that change possibly predict alcohol use at follow-up? So we ran a couple different tests, and what we found was that those who experienced greater improvement in daytime-related impairment, so daytime sleepiness, those individuals reported less drinking at follow-up. Now, this wasn't significant. We're a bit underpowered. We had 42 subjects, but this is a strong effect size. So what do we conclude? And I'm sure others have reactions to the intervention. Well, we were happy that it was feasible. We got them to do it. Again, our retention rates were great. You may have noticed that our number went from 42 to 38, so we did have 4 people drop out, but overall, we were quite pleased that we had pretty high retention rates. In general, they rated the treatment as pretty acceptable, and it was efficacious. It improved drinking, it improved sleep, but we didn't get the main intervention effect that we were expecting. Now, on some level, because we had such strong effects over time, it may be that it was hard for an intervention to then really have an effect beyond that. But as we've kind of taken a few steps back to try to understand the findings, I think what we also appreciate is there were a lot of things going on in both, and there are also common intervention components. So what we thought might have been the unique factors that might have driven certain results, it was probably some of the common factors across both conditions that were probably responsible. And one that was really important that can't be overlooked is the fact that they monitored. They actively monitored their sleep and alcohol use. And that's very powerful for improving any health behavior. They also both got sleep hygiene advice. It was broken up a bit in one condition, but given in just one module in the other condition. But just that advice alone, you may not necessarily have to go into a lot of detail about it, just that advice alone may be helpful. And everybody technically got moderate drinking advice. So all of that, among these individuals who don't necessarily have sleep disturbance, I mean, some of them did, but we didn't require them to have a sleep disorder. So at this level of sleep concerns, this may be enough. We also left with, the important feedback from young adults that, the monitoring was an interesting part of this, but you didn't share any of that information with us. So in terms of the future directions, we didn't leave this knowing exactly what was effective. And so we have some more intervention development work to do. And so I have an R34 application that's under review for this February, so fingers crossed. And we're interested in trying to clarify which intervention components were effective. So in this grant, what we've done is we've tried to really provide adequate control conditions where some people aren't monitoring their sleep so that we can better tease this apart. We're also going to be incorporating feedback to see what that actually adds to just self-monitoring. And what's really exciting, for those of you who may not be familiar, there's actually some new technology that's come out, alcohol biosensor technology that kind of looks a little bit like my Fitbit. It's really discreet. You wouldn't know what it is. And it's really exciting because it can continuously monitor blood alcohol levels. And this would allow us to have individuals use both a sleep monitor and an alcohol biosensor, and we'd be able to provide them with really tailored, personalized feedback about the links between alcohol use and sleep as part of a feedback intervention. And we imagine that the sort of next generation of this intervention is not for it to be a standalone web-based intervention, but really to be an application so that they can interface with this particular app when they need it. It can give them feedback. And I think a part of this alcohol biosensor technology that's interesting is I think if you want to promote multiple health behavior change, which is a big interest of mine for this particular project, some of these applications, like Fitbit, for example, they probably are going to need to move in the direction where they start to provide you with feedback about the intersection of behaviors. So when I log in the morning and I see how much I slept, I see how many steps I did, Fitbit should be trying to kind of tell me how these are all connected. So on days when I didn't sleep as much, maybe I didn't do as many steps. And if you could show me the parallels between my behaviors, maybe that might facilitate better changes. And that was kind of the feedback we got from the young adults that, I might be inclined to change my drinking if I knew that it was so important for my sleep. So with that, I'd like to close and acknowledge my collaborators here at Yale and my collaborators at Brown and the students who've helped me, and see if there's any questions.
Great talk and so many interesting issues. One thing that I noticed is that in your experiment, if you could use the temperature of the CMHC auditorium, you might have better sleep results in your study. For me, one of the big unfilled squares was the question of depression. Mm-hmm. So particularly your worst off group is having difficulty falling asleep, which is a cardinal symptom of depression.
Right.
That your other group isn't. There are a number of reasons that I think that the depression would be interesting. I suspect you measured depression through your study, and I'm wondering how it fits into what you told us today.
Yeah, great question. So I would say some of the other studies, when they've looked at what is the unique predictive power of sleep relative to other issues, some of these studies, when they actually included depression in the model, they lose the unique association with sleep. Some aspects of sleep, like sleep timing, potentially are holding as more unique predictors, but you're right that a lot of this could be accounted for potentially by depression. Interestingly, in our sample, we did measure depression. We used a NIH PROMIS measure. But they actually didn't really score as high on that. What they actually scored a lot higher on was anxiety. And so, we haven't actually gone in and looked at potentially these changes in depression and anxiety, but that's an important question that we need to probably see if that's potentially a driver.
The second thing is that you have people are wearing something that is like a Fitbit.
Mm-hmm. Right.
So many people would suggest that exercise, the level of exercise or activity would be a moderator, is a way that people manage anxiety and depression in a
Right.
constructive way. And I'm wondering whether you looked at exercise as a mediator of that. And one of the reasons I'm wondering about that is it looked like in your health behaviors modules you addressed exercise explicitly, and you didn't seem to address it explicitly in the night, and call it a night module.
Right. Yeah, that's another great point. We have in the diaries, we ask them about their daily exercise use, so we could go back in and look at exercise as a potential moderator.
Could you pull it right off the Fitbits? Because that
So-
would be quantitative.
Right. So the ActiWatch, it gives you an index of activity. So it probably doesn't necessarily give you kind of steps per se, but what it does is it essentially tries to look at during this phase you were inactive and likely asleep, and during this phase you were active, but it doesn't necessarily give like an indication of steps. It's a little bit different.
Because it raises this broader issue, which I think is really important in clinical research, is increasingly it would be nice to use passive data collection.
Right.
In other words, to use the data off the Fitbit as a index of activity, rather than requiring people to report on it.
Right.
For a number of reasons.
Right.
Reduce respondent burning, greater accuracy,
Right.
fully quantitative as opposed to semi-quantitative, things like that. So I think it's a really interesting direction.
Yeah, I think we could, like I said, look at activity. It's probably not as ideal as the step counting that the Fitbit does, but we could look at that. Definitely. Any other questions? Yep, Sujitra?
Along the same lines as what John was asking, what about performance per se? So in the sense that how they are performing in college, or their grades, or how important those are to them, that could be another measure which could be important to them, and you could provide feedback on if there was some way you could link that with the sleep deprivation or with their alcohol use, so to have more relevance for them.
Right. Yeah, at the time we conducted this, we asked them about their grades and their grade point average, because we actually had a number of seniors, so at that point there wasn't a lot of wiggle room in their GPAs, so it was a little bit challenging, but I agree with you that some way that we could give them some marker. I mean, I've often thought, with these devices, could you have them do some sort of, little response type of task, and then you have them do that on a device, and then you can give them some feedback about, you were sleepier today, and, you're, yeah. Yeah. Yep. Question? Yeah.
I don't mean to monopolize, but we can ask questions too. So one of the things that I find intriguing about college students is that the stress level in college builds across the semester. It's programmed. And I'm wondering whether you consider so you have a 5-week epoch at the beginning, and then 3 months later, you're following up. So for some people, that 5-week epoch is heading to midterms. For other people, it's heading to finals or Thanksgiving or something like that. And that 3-month follow-up, for some people, that 3-month follow-up is going to be in the middle of summer vacation. Whereas other people, the 3-month follow-up is going to be right before final exams. And so I'm wondering how you handle that calendar as a moderator of what you're looking at here.
Right, I think that's an important question. We probably have not done that level of analysis where we looked at the specific time of the year when this was conducted. I think we'd have to go back in and check that. I think that's an important point, that for sure when we assess certain people, they may have just been in a better time period. I think also to get at this issue, we've decided that going forward, you probably shouldn't make people wait to get the entire treatment. You should probably just give it to them all at once, and that not only would facilitate better research strategies, because we wouldn't run into this issue like you mentioned, but then it would just allow people to just have access to all that they need right at once. But yeah, it's an important point. We have to go back and look at, really understand the actual time of when these were administered to understand if there's a moderator there. Yep.
So
Sort of a follow-up to that, do you have any norms? When you had such significant drops, what is the typical student do drink-wise over a course of a year? You said a lot of students were freshmen, I thought at first, but then you had more seniors, so I don't know where in the system you were.
Right. So we actually had the smallest amount of freshmen. We actually had more other classes that were distributed. Interesting. I don't have it here. I usually include it in my presentation. But when we actually look at college drinking levels, we actually see that drinking increases over college. So it actually, college freshmen are not the ones drinking the most. When you look, epidemiology data actually looks across college years, you actually see that the most drinking is occurring among the seniors. So I think that we actually were tapping into the group that was probably heavier drinking. Yeah. Becky?
So one, I'm wondering what you think would happen in a more heterogeneous non-college sample. And I don't even know the validity-wise, is there more drinking in that population or less?
Right. Yeah, so we decided in the R34, the follow-up to this, that we wanted to open it up to young adults more broadly, so not to restrict it to college students. Young adults out of college are drinking the most, so up to 25, that's when we're seeing really the heaviest rates of drinking. And again, those poor young adults who I was depriving of sleep and having them come in with Everclear and Kool-Aid, Stephanie was there with me, and it was about as hot as this right in here on one of the occasions. So in terms of looking at alcohol response, make people really hot. And so what we found is that they are maintaining pretty bad sleep schedules. So they still have this preference to sleeping a bit later, but then they have to go to work now. And so we think it actually has more relevance to the broader group of young adults than just college students.
Thanks, Lisa. That was great. I'm wondering too, also with our young adults that we see here in our young adult service, I'm wondering if you could also use this as an intervention with cannabis and other substances that they're using. It seems like I hear more about their use of that more than alcohol. That could be a cost issue or whatever, or accessibility.
Yeah, we actually did include in the call to night intervention, we included information about stimulant use and caffeine use and cannabis, not just alcohol. And we didn't have as many cannabis users in our sample, but I agree. When we had the focus groups, we told them, there's not as much data on cannabis, but it does suggest that it's probably not a great strategy for your sleep. And so we provided them with the actual data up to this point that we know of in terms of what are the effects on sleep, but I agree that I think they may have this perception that it's helpful, but it actually isn't, and they may benefit from that. Okay, well, thank you very much for the opportunity today.